Looks like we're starting. I think I have chats running. Not really sure. It looks like X says it's streaming data. Looks like we're streaming on all three. We're running a little different software today, so we're going to see how this goes. If it doesn't go well, then there we'll have it. But we're streaming a little higher resolution. If you are there and you can see this happening, can you, there we are, Nomad over normal, helping me set up some camera. Hopefully it looks good. We're streaming differently. It's a party tonight. Glad to have you guys here. Eileen, good to see you. See you on Monday. Cannot wait. On the way from Jersey. Oh, okay. So apparently I need to change the YouTube title. Here we go. Thank you. How do I do that? Update titles. Oh, YouTube, you stinker. Hold on one second. All right. Okay, so we're gonna get going today. Well, everybody can hop in, come say hello. We're gonna do Q&A today. Because why not? Number one, and number two, we've had a lot of good questions lately, and I want to just have time because I have a bedtime. And if I don't get my beauty sleep, then everybody, well, people don't suffer, but I get tired. So, okay, cool. So we got Big Arm. What's the theme? The theme is you guys. We're going to talk questions. Hopefully we'll see what comes up. If not, I got ideas, but I wanted to give you guys a chance to just answer questions from the top. Bella, interested about short clip about stairs and blood not getting to the brain. How do we improve this? Let's talk about that in a moment. We can get to that. We've got Del Tate in the house. Great to see you. I don't think I've seen you on a stream yet, so that's pretty cool. Irene says hello. The Fairzuck. Welcome you. Ooh, Fairzuck, it is late in your neck of the woods, but I'm glad to see you. I imagine you're probably streaming this from the club right now, so that's probably hard to hear me, but I appreciate you being here. So thank you all. Thank you all. And let's get to it. So first question, Bella asked, I had a short clip about stairs and blood not getting to the brain. How do we improve this? Okay, so let's start there. Sorry, all of a sudden a lot of highs came in. Megan says hello. Suze is there. Love it. We got Peace, Love, Mung Bean. And let me see if I can save these. No, those are just blocks. Never mind. Not going to block anybody. Okay. Dr. Cadwell is here. Christy Lee, hello. Sandra, hello. Okay, so I'm going to try to grab the questions as they go. It's a little different in terms of how this is organized, so it's going to take me a second to catch up, but I think the video quality is better. And if we do a good job, I might be able to repurpose some of these videos into shorts, which would be helpful in my life. So thanks for hanging with me on that. So, okay, so we were talking about stairs and we were talking about blood flow to the brain. Sorry, I'm getting distracted by all you guys chatting in the box here. It's pretty fun to watch. Because we got Fairzuck. It's 2 a.m. I think you want to say 2 a.m. So I got to just keep him awake and we just got to shout at him. Cool. Okay. Okay. So, we're talking about stairs. Sorry, I keep getting distracted. All right. So we're talking about stairs and blood flow. And so for a lot of people, we had this conversation in the clinic maybe last week, 2 weeks ago. We were talking about going up the stairs. And when you're walking up the stairs, that can be like a little extra difficult for a lot of people if we're already kind of running low on the budget in the brain. And the reason that can be is because when we walk up the stairs, we're demanding a lot of the big muscle groups in our legs. So Big muscle groups in your legs means you need to send blood to them, and they can absorb a lot of blood because they're a big muscle. So you kind of think about it like when I am walking up the stairs, stepping up the stairs, I'm kind of pulling that blood down to be used in the muscles, which means I'm pulling it out of the circulation that goes from the heart to the brain. Okay. And if that's true, then walking up the stairs can be particularly hard. So a lot of people across illnesses, whether they're acute illnesses or chronic illnesses, whatever, will notice that like walking up the stairs will put you out of breath because it's already work. So if we add that to the fact that we are already pulling out of kind of like a lower level of circulation than normal, a lot of people that are in the hypocapnia world and hypoperfusion world will notice that stairs are particularly hard. So one of the ways we try to solve for that is, it seems simple to say, but we have to be able to both put blood into the muscular system, but then also into the brain at the same time. And it's actually shouldn't be that big of a deal, right? People run all the time. People walk up and down stairs. They climb mountains, and they're able to do these things conversationally. So what would happen where that's not available is basically where we get a misappropriation of that blood flow. It doesn't go where it needs to go in the budgeted time that it should be there. So it gets distributed poorly. And that's a lot of what our conversations are about, is why is someone's circulation being distributed inaccurately? And a lot of that comes down to how well the architecture, the maps of your brain are able to distribute both to the right place and in the right time. So how to fix it? Well, we have to understand why. So, we have people here that some people have peripheral nerve problems that cause it to be more difficult to be able to constrict the vasculature. Some people have problems where we have errors in the map that mean we don't control certain areas as well. We see pooling, we see different accumulation of blood flow in areas that don't allow for recirculation. Sometimes we see the baroreceptors or the detectors of blood flow in the neck aren't kicking in very well. And if they don't read the temperature fast enough, not the real temperature, but like the temperature of pressure in the artery. Forget I said temperature. Don't read the pressure in the artery very well, then we see a delay in that response, and then we affect the way blood pressure goes. So, and on and on. The moral of the story is these are little things that people will notice that are clues. If I'm walking up the stairs and I feel worse, that's a clue that we're drawing out of that system, and we got to figure out a better way to budget how all these things are working together. So hopefully that starts to answer that question. It's not a specific answer. It's not like if you do X, then you'll feel better on stairs. It comes back down to like, why did it go bad to start? Okay, so let me see where we're at. Probably we've got some more hellos here. Tracy says hello. Sandra, Irene said, you made my month today with the reel we posted on Facebook. On the recumbent bike, where is it? The savable version of this reel is the bolster on her upper body weighted. Excellent question. So yeah, so we just showed an example of what we're doing on the recumbent bike. Nomad over normal has been really, really gracious in being able to share the journey there. And maybe they could speak to that a little bit. Whoa, I'm already way behind. Okay. Man, I gotta get faster. Okay, so yeah, so we use different variability in recumbent bike. So we kind of rig it up in a unsophisticated way maybe, but we start with laying on the ground for a lot of people, trying to work on maintaining isocapnia, which is really important in the way that we exercise people, meaning we keep their CO2 levels so that we can focus on autoregulation. And there's really cool reflexes that we have that allow us to be able to, no matter what is going on in our body, you guys will appreciate this. So no matter what is going on in your body, the blood flow to your brain should kind of stay pretty stable. And we call this a dynamic cerebral autoregulation, which just means no matter what's going on, neck down, I'm running a marathon, I'm taking a nap, the stability of blood flow should remain relatively constant in the brain. And the tools that we have for that are largely around autoregulation and vasoreactivity. Okay, so those are two reflexes that live within the blood vessels in your brain. So when we're exercising people, a lot of times we're doing that for people that need to work on the autoregulation side. We need to have them better at detecting changes in the vasculature so they can more regularly modulate the dynamic cerebral autoregulation. I realize that's a lot of words, but it just basically means we can keep the blood flow stable in the brain across different modalities. So one of the most important ones is during exercise, because that's where most people are struggling. Make sense? So if they're struggling in exercise, what we can do is we can hold their CO2 levels stable and high enough so that we can exercise the autoregulatory system. And today we got to do a little acceleration where we were able to go from laying down to doing like a modified recumbent version, actually just using a simple weight bench where we just put it on an incline so we can start to incline really simply coming up and be able to get a little more tension on the system. So it's really cool. It's really useful and it's fun. It's fun to watch people excel with that. So that was a fun game today. So is the bolster on the upper body weighted? Not in this case, they can be, but it's actually things we're using because we're using a Neuro 20 suit. You heard me talk to Dr. Cronin about that maybe a couple months ago, that has electrode stimuli on the body that help amplify some of the signals. And sometimes if the suit is a little bit loose, it doesn't connect as well. So we'll use just a little bit of weight to help hold the electrodes on the skin so they don't get sparky. But good question. Okay. Bella says, hello, everybody. Friday morning in Australia. Sandra's in Miami. Is there a good general conditioning program that you can recommend for severe OI? Yeah, we actually had this conversation today. So orthostatic intolerance as a general conditioning. So this is kind of like saying, like, what could you do if you're just trying to like maybe tread water, maybe get a little bit better than where you're at? Most of you are aware of the modified CHOP protocol that is modified from the Levine protocol in Texas, and then they modified it in the Children's Hospital, Pennsylvania, and then it's been since modified a bunch of times. But basically, the long and short of it is a style of recumbent exercise. This particular style of recumbent just means like not upright, so basically sitting down, laying down. This style of exercise was actually born out of looking at astronauts that were returning from outer space. Cool. So you have people that were largely like really healthy people going in. As you know, in order to be an astronaut, you got to be like a pretty fit person to start with, right? You're like a pilot. So you start out pretty fit, but then when you go into space, you're just outside of our ionosphere, outside of our atmosphere, outside of our gravity. And then so all the normal receptors that are active within the body on Earth, they aren't getting any stimulus, so our body starts to have to compensate for that. So we get muscle loss, we get bone loss, we get atrophy in the brain. Like, it's pretty gnarly to be in space, actually. So what they decided was, and we saw this just maybe a couple weeks ago, maybe a couple months ago, when we brought back the people that were stranded at the International Space Station for a while. When they got off of when they got out of the module, shuttle, whatever they were in, you could see that they wheeled them out on a stretcher, on a recumbent stretcher, because their muscles just aren't super strong. They want to make sure they're safe and healthy and all of those things. So when they come back, they'll have a reconditioning program that is helping them to reacclimate to gravity so they can get going again. So they're building up muscular strength. They're building up bone strength, being able to recalibrate their otoliths, their sense of gravity, and then their cardiovascular system. So that is where these systems were born. I think the important part of this is, okay, let me step back. So that was translated saying like, well, in POTS, we're having this failure of cardiovascular return. We're not getting enough blood flow returning back to our heart. By exercising, it forces the muscles to push blood back to the heart. And if you lay down, you don't have to do it against gravity. So you can kind of readjust that way, which for some people can be really useful tool, because it's just like a brute force way to get more blood back to the heart. Cool. Now, the secondary component of that, though, is the way the program was designed. it's designed with the assumption made that the exercise systems that people have are functional. So when they run the program, when they run the machine, it does the normal things and then therefore kicks on and gets going again. What that doesn't account for is that in conditions of orthostatic intolerance, we kind of know on the front end, because we lose the ability to exercise, we know on the front end that the mechanics of that system are already failing. So there's something about that system that already doesn't work. So if it doesn't work, the idea that we're just going to like train it and then it will all of a sudden magically start working again doesn't work for everybody, right? And that's kind of the rub where people will try and they'll really, I've seen a lot of people give a ton of effort to really being focused on exercise. They feel like they're just kind of like they're just grinding at it. And I think that that's still useful in a lot of ways, but it's maybe not solving the big problem. It's not kicking over the big domino. So that's a long-winded way to say like those things are available. Those are kind of the industry standard as it currently sits. But my advice for everyone would be to try to maintain their current degree of activity, whatever that is. Because one thing we know is that number one, it's hard. I don't take that away from anybody. It's hard. Like when you're going through this, maintaining normal activity levels, it's difficult. It's work. But also, when we don't maintain them, it becomes a slippery slope of losing functionality. And the more functionality you'll lose, a lot of people will tell you that the harder that is, or the more work it is to start to get it back again. So like the farther you let that backslide, the more ground you got to make up on the back end. So to whatever degree you can, and you're a rock star and you're a fighter and we love you, try to maintain your activity levels. And that can be through whatever you can do. For people with orthostatic intolerance, a lot of times if it's safe for you to be in the water and you're not going to pass out or risk your life, being in the pool can be really helpful because the hydrostatic pressure, the water pressure, can help to return some of the blood to the brain and allow you to be active within that scenario so that you're still feeding the brain. That can be really useful. Recumbent exercise can be useful as long as it's at a dose that your body tolerates. Anything that you can do to continue to be upright, to continue to be doing the normal things in your home, those are all useful strategies, even though they may not ultimately solve the problem. They will definitely make it easier for you to be able to maintain your lifestyle and have a jumping off point once you know what problem you're trying to solve so that you have less distance to cover to get back to normal. Okay, so long answer, but I think it's useful because I think a lot of people wonder that too. Dancing P also says hello from Miami. Trish Land. Okay. What would you suggest to do for heavy heartbeats? Not fast, just heavy. It can go on for me for days and weeks and then just disappear and reappear out of nowhere. Okay, so a heavy heartbeat, or otherwise known as a palpitation, where it feels like boom, they're just really big in your chest. There's a thing to consider. So a picture that I often find myself drawing, I'll try to draw it here for you guys. Give me just 1 second. I'm going to move some stuff around. And then let me change this over. Give me 1 sec. Let me update this. Okay. Sorry about that. Still getting used to this here. Okay, so if you think about your heart, it's basically a pump, right? So you got your heart anatomically correct, but it's a pump. So it's got this left ventricle that's pumping blood out, right? So as it pumps out, each pump, it should just be moving through here, no problem. Anybody who's ever taken like a big jug of water and tipped it upside down knows that it's going to glug. You know, you see the big air bubbles come out when you're trying to dump it out of that jug, right? So why does that happen? So as soon as you take a big vessel or a big tube with a large diameter, and try to make it go through a smaller hole, a smaller diameter, then we're going to get what's turbulence. So just like you'd see in a river at the river bend where the river swirls, it creates turbulence. So the same thing happens here. So if I start to get areas where that lumen is compressed, okay, wherever the vessel is compressed, as I'm trying to push through here, I'm going to get this little swirl of blood back. And as this creates a back pressure or retrograde flow in the system, it's going to make the valve in my atria, this is a terrible drawing, but the valve in my atria that opens up to let the blood flow, after the heartbeat, it snaps back shut and the blood hits against the leaflet. So they kind of go like this, where they're like this, the heart pumps, and then they snap shut, and then the blood hits against them. And that's like the audible part of your heart sound that we hear. So when we have a restriction in the flow at some point anywhere in the system, but if it comes back and you feel it in your chest, the likelihood is that you're feeling it kind of give you that turbulence back against your heart. So some people will really notice this, for example, after eating, where their stomach's full, it's kind of compressing against everything. It may make it harder to push blood through the abdominal aorta, and they may find that they feel their heartbeat heavy, right? You may find some people will notice this if there's turbulence because you're having like a headache and you feel the heartbeats in your head because you get constriction in the blood vessels in your head. So the simple way to think about it is whenever we have, this is a generalization, but whenever we have something where we have a big tube and we shift it to a smaller tube, then we're going to have turbulence and we're going to feel that retrograde flow kind of go back into the next area. So sometimes you'll feel, like I notice this with my kids, if I've eaten and then my 5, soon to be 6 tomorrow, when she sits on my stomach, I can feel my heartbeats in my stomach where it's having a hard time pushing through the abdominal aorta, right? Or like if you're laying funny, you might feel like a pulse in your head, or if your arm's cocked over and you're restricting a blood vessel, you might feel it in your fingertips, or you might feel it like up in your arm. So all of those are moments where there's a high likelihood that we're looking at turbulence in the flow. The other place that people will notice it is if we have just like a big adrenaline rush. And in that big adrenaline rush where you feel your heart beating really heavy, it can be because of the contractility of the heart as well. So when we see that the heart is just beating harder, right? The inotropic value of the heart is more, then we can feel that. So these can also be medically induced. So things like ivabradine, to some degree, midodrine, like volume expanders can cause you to feel some of those heavier beats as well. Cool. And they come and go maybe based on how that vascular system is being manipulated at any time. Sometimes it's the food you eat, can make it a little harder to digest. Sometimes it's positions you're in. Sometimes it's stressors, but they can all be on the list. And a lot of people will notice them also more laying on their left side because your heart's closer to the chest wall on the left side. Okay. All right. Ms. Bradford says, where does shortness of breath or air hunger come from if oxygen levels seem fine? So the circulating levels of oxygen that we have can not necessarily indicate like to what degree we feel like we need air. A lot of our respiration rate is actually driven by CO2 levels, and a lot of that is done by sensors in the medulla, in the brainstem. We also have them in the lungs, and we get feedback from the lungs. And we also have them in the arterial system. Baroreceptors have sensors for oxygen, CO2, and glucose, which is kind of cool. And we sample that into the medulla. So what we want to pay attention to is if it's a perception of shortness of breath and the actual breathing is okay, or is it where our breathing is becoming labored or difficult, or it feels like we're not able to get a full breath in. Or we can have mechanical obstruction of the ribs where we're not able to mechanically expand the lungs. So people will notice that when we're in kind of these more kyphotic positions where we're tilted forward, or if the lumbar curve is non-existent. So if our lower back is rounded, because it can make it harder for the diaphragm to pull and expand the lungs. So if you try that right now, one thing you can look at just to get a sense of it is if you slump forward like that and try to take a big deep breath through your mouth, you'll notice that there's like a lot of muscles that kind of get stuck at the end of that. It's not as good as if you stick your belly out and take a big deep breath. You'll notice that you get a lot more expansion, and your ribs won't necessarily even move as much. It happens from the mechanical advantage of your diaphragm. So those are mechanical reasons that it can happen. It can happen because we get changes in CO2 and oxygen levels at the level of the brainstem. CO2 levels can be a big one. Okay. And if those CO2 levels get low, then we can start to feel like our breathing gets more labored. And we might start to breathe a little more shallow and a little more rapidly. And then, so those are things to consider as well. And then sometimes just the failure of the central respiratory generator, or the feedback from different areas in the brainstem, if it's errored, then we can start to get changes in the patterns of breathing. So the actual, like the waveforms of those patterns change. And a lot of people that have other autonomic findings will notice this as well. So things that are stressors, things that create overwhelm, doesn't matter, they can be external or internal, can start to yield those types of problems with our breathing. Cool. Irene says that reel of this is Christy Lee, but I don't know how to say her name and her handle here. Choreo Bicum. I don't know. You tell me if that's right. That's her. That's Irene's recovery position, is kind of in that laid back recumbent position. So we kind of figured that one out in trial and error. One of the things that we noticed was I had a recumbent bike for a while, which is like a chair with a bike on it. And one of the things I noticed was it makes your hips be at like a 90-degree angle when you're riding, so your knees kind of get up high. And what I noticed with that was we would get people, so you have these, like you have your abdominal aorta that comes down, but then it branches into your legs and the two iliac arteries, and that comes down in the femoral arteries in your legs. So you get these big arteries that come down in your legs, but you kind of kink them off by having your hips kind of compressed. So we were finding that when people were exercising, they may not actually be returning blood as well. So we were seeing people that even though they were pedaling, they were still getting some pooling in their legs. So that's why we started opening the hips up, and we actually have a stepper in the office as well that allows you to do that on a recumbent basis. But the more we let them open up their legs, the better it was, because we got a system that's really crappy at returning blood, then we don't want to like make that harder. So so when we're trying to return blood through the venous system, we want to not kink off. I'm sorry, I think I said arteries, I meant veins. But we don't want to kink those veins and prevent the return. So we use that recumbent bike. It's actually a regular bike that we use in different levels of recumbency. But one of the things we focus on is trying to let the hip angle open up so that we can allow that blood flow to pump more freely, if that makes sense. Sandra says she's having terrible brain fog, unable to stand up because of the pulling down drainage sensation. Nobody seems to understand why. I'm feeling so bad. Okay, sorry. I'm sorry to hear that, Sandra. Yeah, maybe there's a question in there. Yeah, I'm sure a lot of people here totally understand that feeling, and it's really frustrating. For sure. I'm with you. Okay, is there any way to treat internal jugular vein compression and thoracic outlet syndrome without surgery? I would say, yeah, like that should be the first line. Like surgery as a first line is, you can't really, it's hard to take a surgery back, right? But conservative treatment, you know, the worst case is that you end up in a more aggressive treatment strategy typically. So internal jugular vein compression can occur just from simple misalignments in the skull and the upper cervical vertebrae. It's super common way to present. Obviously, there can be a lot of nuance in the way that looks, but being able to control that head and neck position and movement is a great first step. Thoracic outlet is super respondent to even just simple physical therapy. A lot of thoracic outlet, basically the thoracic outlet is, I've got nerves, arteries, veins that travel like down under, like from my neck, down underneath, behind my clavicle, in between my clavicle and first rib. So if you feel there, there's like your big bone right there, that clavicle. And then behind that, there's another bone that is your rib that kind of goes around the back. And then you have all of that little bundle of goodies, blood and nerves, that come through there. And with different shoulder positioning, you can kind of block that. And the easy way you find it is you can just see if there's response of muscle activity. We get weakness in the hand typically. Easiest way to look, a little tidbit for people. So the nerve fibers that'll be affected the most are the ones at the bottom. So they're the ones that come from the C8 disc and the T1 disc, and they come around. And if there's compression against that rib, usually it's the bottom ones that are going to be affected the most. So people will oftentimes, like if you're typing or working at your desk, you might get some numbness and tingling on the lateral part of your hand, like where your pinky is, usually kind of right over here first, maybe even the fourth digit as well. And sometimes on the outside of the hand, you'll notice it. And then what you can do is we have people hold their hands like this, like that. And then we can just have them squeeze their pinky in. Anybody that's been in has probably seen me do this. And you're just going to try to pull that pinky out or have someone do it. And what you'll notice is it should be able to kind of hold itself in and snap back pretty well. But what you'll notice is in that thoracic outlet side, it'll be weak, where it'll just kind of be hard to hold it in and it'll be slow to come back. Okay, so that's number one. That's for like a neurogenic TOS. And then if we look at vascular, then we're just looking at, is it compressing blood vessels? Obvious way to do that. There are several TOS tests, but you just look at, can you feel the arterial pulses in the median and ulnar sides? And then if you rotate the arm out, if you stretch the arm back like a doorway stretch, or if you compress the clavicle and turn your head away, do any of those things cause the pulse to go away? And then a really simple way to do it, if you're just kind of screening, is you have people put their hands behind their back like this, and then you check that way as well. And you see if the pulses go away. And a lot of you can do this and feel like my fingers go numb. So there's a sign. So those are kind of the quick and dirty ways that people check for TOS. And then what you do is basically saying, how do I offload it so I can hold that clavicle up and create space again? For most people, that's not necessarily a surgical problem. I would say even though we're online, everything lives forever, like the vast majority of people probably don't need that resolved surgically. They can probably do it through strengthening, being able to like have a little bit of extra trap activity that allows them to be able to hold that shoulder up without it internally rotating and kind of rotating down like that. Most of you will notice that kind of makes the symptoms worse, but being upright and lifting your shoulders up a little bit will let that off. So lots of opportunity there, lots of opportunity for upside. Also, another little tidbit, since we're on this topic of thoracic outlet, on the venous side of that, the vein draining side, one of the things that you will often see is when we hold someone's hands up overhead like this, it'll just drain. Their hands will get just white. They might get weak or they might get numb being up there, and they might get really cold. And that can also be a signal that we're having a little bit of occlusion on the arterial side, but people might also notice that they get heaviness in their hands if the veins are getting congested. And when their arms are up, they might notice that they start to feel a fullness in their head. You might see the veins in their head and neck start to bulge out, in which case then you're looking at retrograde flow that could be coming from not being able to drain the subclavians. So just things to think about, but definitely amenable, actually fun to work on, and usually have really good results. Cool. Okay. Scott, hello. Robin here, loving the microphone and high def setup. Thank you very much. Working hard at that with some help from Nomad or Normal. Ann says, good evening. Priscilla guesses that she's had POTS since a child. Okay. Farzak says, the stairs problem also applies to walking up hills, right? Yeah, absolutely. It's surprising. He says it's pretty surprising the heart rate change from walking flat and walking with the slope, for sure, because it requires just more muscle activity. If you can think of just like at your healthiest walking up a hill, that's where the legs will burn, right? Walking up a mountain. So it's gonna demand more activity, which means it's pulling it out of circulation. Practitioner says polyvagal regulation with a light bulb, reducing inflammation. I'm not sure, that might be in response to something I said, but I'm not sure what that is, or if we're just like doing that with high five. Irene McBean, I asked if the bolster was weighted because sometimes a point of contact or weighted or light pressure stimulus is helpful for her disequilibrium. That is an excellent point. So for a lot of people that experience that disequilibrium, and we've been having this conversation all week, by being able to increase the sensory feedback allows you to create a better picture of your world in your mind. So it allows you to be able to have a higher resolution, like my new camera, a higher resolution of your world, which will then shrink the like deficit of postural response. So if you think about disequilibrium as being kind of the sensation that your ellipse of posture is too big, by giving a better sense of where you are in space, it allows the reflexes, so our postural reflexes, to have a tighter feedback loop. Everybody has, I guess I should have mentioned, everybody kind of has an ellipse. So when you breathe and when your heart beats, if we stand still and close your eyes, everybody, when we measure them on a force plate, has just a little bit of forward to backwards, but it kind of goes in a little bit of a circle, but it's mostly forward to back. When we start to lose some of the sensory acuity from our body or from our inner ear or from our vision, what will happen is, because that feedback loop is less, the tightness of that control is less. So we see that ellipse start to expand. So we may notice that it gets bigger in this plane, but it also may start to shift and move on a diagonal. And that's what people with disequilibrium sometimes will notice, is that they kind of feel internally like they're doing this ellipse, right? So by being able to use weight or a weighted blanket or even just a touch, we give an anchor, we give a signal from the world that kind of lets us know where we are in space, which increases the feedback, which means the motor output allows for a smaller ellipse and a smaller sensation of disequilibrium. So great point by Irene, but it's a really, really great point to drive home, especially for people that are dealing with maldebarkment, people that are dealing with disequilibrium related to sensory loss or from vestibular loss or from changes in their vision. Cool. So I hope that helps. All right. Anne was responding to Megan, said she's got air hunger and oxygen levels are normal. Thinking it has to do with adrenals. It is likely not due to adrenals. And the reason for that is your adrenal glands are going to emit a couple different substances, but they're mostly regulatory hormones that are responsible for their glucohomeostasis mostly. So if we're having air hunger and oxygen levels, a lot of that's not super detected in the adrenal glands, and the adrenal glands are a motor gland, so they don't have like a huge sensory system. They mostly take their orders from the HPA axis, or the hypothalamus, and then the hypothalamus gets its marching orders from the prefrontal cortex, largely, also the reticular cortex, but these areas that basically control outputs from the brain that then come down and talk to the periventricular nucleus and then give some orders that are maintained through hormones. The adrenal gland is a gland, so it'd be like kind of like saying like your lacrimal gland or your your salivation gland would be relevant to oxygen levels. It just, the likelihood is low. The job of the adrenals is to emit a chemical, and those chemicals are largely due to being able to maintain glucose levels, energy levels as their main tracking point. So not a big sensory change in the adrenal system, more in what we're looking at in the brain. It's important though, because you'll see, and this is not to be disparaging here, but it's a very good point, because the adrenals kind of get thrown at everything. Somebody had mentioned the other day that somebody posts about adrenal fatigue being a common cause of orthostatic intolerance, and it's like very likely not. And why that would be is because you think about what is being released, or how do you diagnose adrenal fatigue? Okay, so you diagnose adrenal fatigue. Well, number one, there's a large subset of the world that would argue that adrenal fatigue is a thing at all. barring that, withstanding, so let's say you assume it is a thing, then you would say, like, well, you look at diurnal cortisol rates. So you do 4 salivary cortisol tests in a day at different points throughout the day, and you just look at the rhythm of that. And the suggestion is that we'd be out of rhythm or low. Problem with that is if you look at low cortisol production as an indicator that the adrenal gland isn't working as well as it should be, then you say it's hypoadrenal function, which has the name as Addison's disease, if it's to a degree where we actually see the adrenal glands failing. But what we see in adrenal fatigue is that's probably not the case. And if we were saying that cortisol levels being skewed are an indicator of orthostatic intolerance, people will say it's because your fight or flight systems are activated. But if that were true, then the cortisol levels, that's not really a good way to think about that, because if cortisol levels are low or dysmetric, then we would actually see a decrease in energy production. Because the main function of cortisol, everybody talks about it as a stress hormone. That's not its primary function. The primary function of cortisol is for glucose homeostasis, meaning it helps to regulate gluconeogenesis at the liver, helps with converting fat and protein into like different types of energy sources. So its primary job is not as a stress hormone. The primary job is to liberate glucose and to stabilize against insulin. So it's like a glucose-mediated chemical that, as a byproduct, if you need a lot of glucose because you're under a lot of strain, or we could say stress, like we need more energy, then we're going to demand more of that glucose system. And here's why we see the correlate with insulin levels and reactive hypoglycemia and these types of problems, because when you look at like a functional medicine approach toward adrenal fatigue, what it really is glucose management. So we're actually looking at dysglycemia as the primary problem that's often treated, and is treated by changing dietary habits of protein consumption, meal timing, and then using different types of adaptogens to be able to kind of regulate that. So I think that's really important, though, because what we're really talking about in that system is a glucose problem. So like glucose regulation problem, not so much orthostatic intolerance. So if your tachycardia exists as a function of your dietary pattern, then we really want to pay attention to, are you dysglycemic? Do you have reactive hypoglycemia? Do we need a glucose panel and learn how to understand how to regulate glucose levels, how to regulate insulin levels, so that we're not having these energy spikes that yield kind of similar looking findings where you might feel lightheaded, you might feel shaky, you might feel like you're having some orthostatic intolerance or some volume troubles, but they could be relative to glucose control, which is a very good place to start if you're kind of in that boat. If you notice that your symptoms are worse if you're hungry or after you eat, so like if I haven't eaten recently enough, or after I've just eaten, I'm always like in that pattern, then making sure that your glucose is stable is probably a very good first step, because that may be the actual problem, and it may not actually be something that's related to orthostatic tolerance in general. That's like its own kind of separate problem. So if someone tells you adrenal fatigue is the problem, it's probably not. There's not a lot of logic there. It'd probably be more useful to say, like, if I'm noticing those patterns, then maybe looking at my glucose regulation. If that's in check, you check that box off, then kind of moving on beyond that and starting to look not just at glucose, but looking into more mechanisms we're talking about with hemodynamics. That was a lot of words really fast. I've checked 0 messages. You may have questions on that. I'll keep moving down through that. Cool. Hope that one's helpful. Dancing P says, I do walking. It's super hard, but that's what I do so I can get some sun at the same time. I love that. Very happy to hear you're outside, getting some sunshine. Keep walking as much as you can. Tracy Poland says, rebounding. I like rebounding too, especially in the wintertime when it's a little colder. I like to do it in the morning. That's me personally. Some people with orthostatic intolerance, with autoregulatory problems, will notice that when you do the rebounder, you're bouncing up and down. You might feel like your brain's sloshing a little bit. If you notice that couples with, when I tip my head forward, I feel a lot of pressure, that might also be and that also goes with, like, I feel dizzy when I stand up. Those might be things that would point us toward wanting to test autoregulation as a mechanism. Robin, He's been doing Lock 5 and Stuart McGill's Big 3. I love Stuart McGill. Big shout out to him. And agree, exercise won't fix the problem, but it's good to move where you can, to whatever degree you can, whatever that means for you. Just trying to make a habit of doing as much as you can does provide benefit, for sure. Practitioner, so it looks like we're in the part of the comments where I was talking about exercise. So hard giving up on my HIIT workouts for recumbent exercises. It drains me having dysautonomia, but I find it so effective. Absolutely. I love that you guys are doing that exercise. Okay, so I'm going to look at Peace, Love, Mung Bean. That's where we're at. I'm going to drop down here real quick. Okay. Oh, man. You guys are good. Yeah, I'm way behind on questions. I'm at, just to give you a sense of it, I will do my best to try to get through these as fast as I can. Let me see where I'm at. Okay, so I'm basically at the one that was, I'm like 26 minutes behind. So I'm at like a 8:20 timestamp on the question I'm on right now, just to give you an idea of where we're at, okay? So I appreciate you guys just hanging with me, being patient, having fun, helping each other out. I love it. Okay. Why might acetylcholinesterase inhibitors help with POTS? So let's break down what these are for people. So acetylcholine is a neurotransmitter in the brain. It's a pretty ubiquitous neurotransmitter, meaning it's involved in a lot of processes. So acetylcholinesterase is an enzyme that helps with the catalyzation of the acetylcholine reaction. So when you inhibit that, you just allow more of that enzyme to be able to process more acetylcholine for a person. So helping with POTS, this may or may not, I don't know the mechanisms for individual people. I know the results on this are pretty mixed like kind of mixed toward not helpful for some people, but some people had great experience with it, so we won't discount it. But in people, acetylcholine is part of the neurotransmitter profile of peripheral nerves that are autonomic nerves. So preganglionic nerves for both sympathetic and parasympathetic, and then for sympathetic nerves, the postganglionic nerve also uses acetylcholine. So by just providing more in the cleft, if you're able to increase the efficiency of the acetylcholine, you're going to get more output per unit of neural firing. And for some people that may have problems with activating, like, for example, peripheral arterial receptors, may find that they get more contractility in the periphery by doing that. Now, it's the same. One of the concerns with that would be, though, as your body starts to downregulate through the feedback loop and it changes its sensitivity to that. Kind of the same way people use nicotine, or they'll use other things kind of in a like a pulsing format. So it may help, it may not. I don't know if I wouldn't call that one typically a silver bullet for people, but it can be diagnostic in helping them understand which symptoms they need to activate more and try to improve the feedback coupling of those. Okay, tough question, but I'm going to give it a run. Any advice for someone that's struggling to come to your clinic currently? Let's not make it my clinic. Let's just make it like they're trying to travel to seek help, but they're hoping to get some functionality to travel. Like, what can help to make symptoms kind of better? I think this one's tough because I think most people, and I can't speak for everyone, but like traveling when you feel terrible feels like a big hurdle. And that can be kind of a sticking point for a lot of folks. As far as functionality to travel, it's hard because a lot of people that are in really rough shape do travel. Like people coming from overseas traveling over and are able to do that and just kind of like make that happen. And a lot of them do better than they think they're going to do, but that's not saying that that's you. I get it. So things that can help people travel are just trying to maintain as much of your constitution as you can, like your capacity as possible. It's hard to know kind of writ large, like general things people can do. mean, the general things are kind of weak advice because it's like eat well, sleep, hygiene, making sure that you're getting enough activity, like all of those things that are going to sound like kind of trite answers, and I apologize for that. If you're looking for short-term solutions, like just to get through the traveling, that's where sometimes it's helpful to speak to a medical provider that can give you short-term medications that can help with the travel process. And some people find value in that as well. But it's really hard to answer that one on a general basis, because if I could do that, then I would probably just have everybody do the thing that makes them better. And I would just post that, but it's just too hard to cycle through the nuance on some of those. So I understand the question, I get it, but it's hard for me to answer. But if you're like, I just need to travel, I would talk to your medical doctor and see, like, specific to the things that would be barriers to travel, are there things that you could take in the short term that would help you get through that, to get to the other side, and then solve the problems on the other side. So for what that's worth. Okay. Tyson says, actually, HH has a second plan. I'm gonna ask. Excuse me. I'm gonna answer his, and then I'm gonna go to Matthyson's question. So he asked last time, and I probably didn't get it to it, and I apologize for that. If there is times where POTS can mimic Sjögren's syndrome, a lot of things mimic Sjögren's syndrome, because you can have dry mouth, dry eyes, like decreased glandular activity out of the parasympathetic system. But it's not typically gonna mimic POTS, in the sense that it would rely on, like, pan. When I say pan, so like across systems within the parasympathetic axes, in the parasympathetic nervous system, they don't all work together all at the same time. Like, you can cry and not salivate at the same time, right? So you can keep your eyes wet, but also not be like trying to eat at the same time, for example. So people talked about those because the thought was like, well, maybe it decreases some vagal activity, and then that allows heart rate to escape, and then the heart beats too fast. But number one, that would be like a kind of like a pan decoupling of the parasympathetic system, but you wouldn't end up so much with the POTS side of the equation, because that would be independent of orthostasis. But what you may see is just a generalized tachycardia, and you would see an accumulation of parasympathetic type failure, in which case you'd want to address that. But at the same time, they're kind of hard to diagnose, because people that have dry eyes can have dry eyes for multiple reasons. They can be even peripheral neuropathic reasons, like peripheral neuropathy reasons, changes in just like humidity and temperature. Some people will have eye movement disorders that cause increased blinking, which can make the eyes feel dry as well. And then dry mouth can be caused with changes in hydration, sympathetic activity. You'll notice if you're everybody ever know like the cotton mouth sensation, like if you're nervous, where your mouth gets real dry. So sometimes responses where you have higher attention levels or arousal levels, or you're just feeling stressed out, or you're tired, or you're overwhelmed, which a lot of people are. So if you're just getting blasted on a sensory level all the time, your level of overwhelm is going to be very notable. So if you're overwhelmed a lot, you're going to notice your mouth's going to be dry a lot, and the type of saliva that's produced is just different. So in those moments where you're kind of overcooked or you're high attention levels, the saliva changes. It's got a little more protein in it. That's the one that tends to have more odor to it than when you're like hungry and going to eat, and you get that like mouth watering type of saliva. So they're just kind of two different things, and that's what you're paying attention to. There was a big time frame where Sjögren's syndrome was like all the rage, so to speak. Like it was like all of a sudden there was a conference, and then every third patient that came through was like, I'm pretty sure I have Sjögren's. My doctor said I have Sjögren's, but when you test it out, it's not likely. And then it improves when you change some factors with brain function. So that's probably not the case, but some people do have it too. So it's hard. But being able to resolve that on an autoimmune basis is helpful. Doing things that allow you to be able to kind of quiet that immune functionality to slow that down can be really helpful if that is what you're working with. So you just got to try to isolate that and figure out what's going on. But that's a really good question. Good one. HH, love it. Thank you. Nomad over normal. Ooh, this is gonna be probably one I gotta think about. Okay. Chicken or the egg? Question. Neurotoxin binding to mitochondria causing a misfire in the brain, or brain misfiring that causes existing neurotoxin to be the issue. Causes existing neurotoxin to be the issue. Okay, so that's very real. So a lot of people experience these things with exogenous introductions of chemistry. Like this is in the news these days. We're becoming more and more aware of the different chemical insults that we undergo as people. It's kind of wild. We get poison thrown at us in a lot of directions. It's tough. And a lot of them are going to affect mitochondrial output. Mitochondria are very important because where we make all of our energy. And it's kind of a multi-step process, meaning the process of making energy goes through this really long cascade of chemical reactions that allows us to be able to move electrons effectively and migrate hydrogen. So we don't have to get into a Krebs cycle, but it's a reasonably sophisticated system to be able to shuttle electrons through the system in a way that allows them to be separated from hydrogen and then use those to shuttle them back across to make a waveform that allows them to push through and create the ATP. It's pretty brilliant, actually. But neurotoxins can find their way to the mitochondria. And when that happens, we can see energy changes within the cell. It's the same thing that happens, honestly, over long terms with aging, where we see oxidative phosphorylation changes over time. So as you age, you just get worse at it, which kind of sucks as we get older. But so we all gradually lose the ability to do oxidative phosphorylation, which is create ATP as we age. What we see with neurotoxins is they can cause that to happen at a more rapid rate, where the oxidative phosphorylation happens even less. So it like decreases or I guess it would increase the curve of failure there. So so the question that you had there, neurotoxin binding to a mitochondria causing a misfire in the brain, or the brain misfiring that causes existing neurotoxin to be the issue. I don't know. I understand the last part of that one. Brain misfiring that causes existing neurotoxin. I think where we end up here, I might be misunderstanding the question a little bit, but I think the important part is that mitochondrial system is super important for generating energy within the brain. And it is the thing that allows us to be able to generate neuroplasticity in a major way, because we've got to have long-term potentiation, which requires activation or change of the genetic activity within the cell, which is relying on the mitochondria. So we need to have mitochondrial health, or, so we need to have mitochondria. I was going to get into it a little deeper, but I don't want to. By maintaining that mitochondrial health, that allows us to be able to hedge against some of that change over time. So we do want to pay attention to that. The biggest, most important ways are just reducing toxic load, as simple as that sounds. And that you just think of everything that is in your environment that goes from external to internal. So clean air, clean water, clean food. And then the last one that we talk about less is like things that enter your body, not just through your mouth or through your nose, but actually like puncturing your skin. So making sure that we're aware of things that puncture the skin as well. And that could be things that people do to puncture your skin, but it could also be bugs and ticks and spiders and these things that can cause that, or parasites, etc. So all of those things have the propensity to deliver a vector for neurotoxins. So you control what you can control. Some of the things are harder to control. But you do the best you can to be able to mitigate that. And a lot of people, I actually had a conversation with someone today out on the West Coast, and we talked about this as a lot of people will find that taking the effort to mitigate those things to the best degree they can over time can have really nice impacts for people. So, trying to eat organic food that is, from the country that you're in, so that customs doesn't throw a bug bomb in the truck and in your organic food. trying to eat foods that are rich in minerals and vitamins. Big deal. Trying to eat foods that are in season for you, eating an appropriate variety, not eating too much, not eating too little. So like those simple things as far as food goes. Taking care of your water. It's probably worth it for a lot of people to have their water tested and do things to mitigate that, whether that's using a reverse osmosis, whether that's using like a heavy duty filtering system, whether to purchase water. Water can be a super big one, depending on where you're at in the world. Worth paying attention to, worth testing. Making sure obviously food's cooked, we're not getting parasites, making sure you're hygienic, making sure you shower, and trying to live in a place that has air as clean as you can get it. As you can see, Mrs. Dr. Keiser is very happy to put plants everywhere. Now, I don't know from the snake plant study from NASA, you got to have a lot of snake plants in a house to really filter all the air, but it's a great step. Making sure that your air filters in your HVAC systems are clean and using HEPA filters can be really helpful too. So you're just trying to think about ways that you can mitigate toxins entering the system so that you're at least allowing those mitochondria and allowing those neurons to be able to operate without being bombarded by other things. And if you set that up in a habitual way, then it's a little bit of work for the first couple of weeks, but then after that, it just becomes a habit like anything else. That was a long soapbox, but that it's not meant to be like a sermon. It's more like documenting what we like. Those are the things that we do. So at our house, we have a big water filtration system. We test it once a year. We use a testing agency that tests for medications and metals and, organic matter and all the things. And then we just have a big old whole house filter that filters that. Not everybody can do that. If you can do your drinking water, that's my parents. They have a system under their sink. We installed that, and that's what they use. Whatever you can to try to make it better. Trying to eat organic food that's from where you're from, great step. Trying to do things that keep your air clean, a little bit harder, but being in a place where you feel like you're not exposed to everybody else's garbage is probably pretty useful. And then away you go. So hopefully that's helpful. Sandra, the sensation of feeling like my muscles are sucking me down. Okay, sucking me down. So sucking you down may feel like they are weak or heavy, which can happen just with overload. It can happen with, we just talked about energy demands, the ability to do that. So it can also occur with peripheral nerve injuries or compressions. It can occur with blood pooling. It can occur with claudication. So there's a lot of ways to think about muscles being like heavy or weak. That's kind of what I think about when I think about feeling sucked down. And it can also just be with overall energy. And some people will notice that errors in sensory systems that feel like they're unrelated can cause like that lethargy sensation globally through the body. So that's what makes that one kind of tough, is that we feel it where we feel it, but it may actually be the causal component may be something that is extraneous. It might be something that is different, but it weighs on the system to a degree that it causes you to feel kind of that lethargic component. So it makes it a little bit tougher question to answer without being able to observe it and get some data, which would be the really helpful way to look at that. Peace, love, mung bean. I like saying that one. Let me get a drink real quick. Okay, sometimes when people turn their head, they say it feels like something in their neck compresses or crunches. They feel a surge of electricity. What could be causing that? Writ large, and I like the way you frame that question, not medical advice, but when you feel that like surge of electricity, a lot of times we're thinking about what is called a Lhermitte's sign, like French word, Lhermitte. And what Lhermitte noticed was that when his is specific to the spinal cord, right? But when you kind of compress or touch off a nerve, you can have an electrical sensation that travels down, whether your spinal cord going to the nerves or within the nerves themselves. Sometimes people will have that like in their arm where it kind of rolls over the nerve and you'll feel it zing down your hand, or feel like a funny bone, or feel like electricity. So what you're looking for is, if you're feeling that crunch or rolling over that happens and it zings you, then there's a likelihood that we're rolling over the nerve in that place. And then we want to think about, well, what nerve is it? What sort of things would potentially roll over it? How do we work on solving for that? Cool. Okay. Okay. Anjololito, could you please explain dysautonomia and bradycardia? I would love to give that a shot. So it might be useful, since we talk about it all the time, but we don't define it, is to just define dysautonomia. So autonomic sounds a lot like automatic, which is what it is. It's like your automatic nervous system. Another way to think of automatic is reflexive. It happens without your thought. And so dys usually means not working well. So dysautonomia means that part, that automatic reflexive part of the nervous system that controls mostly things related to energy production and management, aren't working correctly. So if something would yield bradycardia, which means that your heart rate is going to be lower, it's going to be slow. Usually slow is somewhere in like, I mean, it's a scale, but it starts getting low once we get towards 60. Once we're in the 50s, that's pretty low. That's getting on the low side. And then if you're in the 40s, that's probably like, we should take note of that level of low, because that's really low. And you can start to have some arrhythmia troubles when it starts to get that low. And that can happen. So bradycardia that kicks in pretty heavy like that the first thing you think of is sympathetic withdrawal. So cortico-reticulospinal system, so from your brain to your brainstem to your spinal cord, is going to control outputs from the top portion of the thoracic cord, and that's going to go to the nerves that go to your heart on each side, like that. So if I get lowered output there, then I may see that the overall charge into the cardiac plexus goes down, and we might see more bradycardia. So these are people that we talk about like vasovagal or vagal responses, where it just looks like that vagal system's super active, but a lot of times it's because we're seeing less of a charge of the sympathetic activity to the heart, which will cause that bradycardia to happen. So that's what a lot of people think about, is that imbalance at the cardiac plexus. And a lot of times with bradycardia, people will start to tinker with having arrhythmias. So AFib, supraventricular tachycardia. Sometimes you'll see this waffle back and forth, not often. Or preatrial contractions or preventricular contractions, PACs, PVCs. So that's where to start, is thinking about that output to the heart, if it's enough. Or if we're having sinus or sinoatrial node problems, so the SA node of the heart, if you have like 6 sinus syndrome, sometimes that can start to cause problems where the overall level of the cardiac output can go down as well. Okay. Brain fog could put my eyelids swelling. So maybe you're asking here if they could cause your eyelids to swell, brain fog. I don't know that you would say brain fog would be causal. They might be causal, meaning like one leads to the other, but you might notice that as you get brain fog, you might have some changes there. I'd like to know a little bit more about what's going on to answer that one, because I'm not sure that I'm clear that I understand it. Nelly says, can the tachycardia or vascular constriction create a transient, so comes and goes, audible or palpable murmur? Yeah, so that goes a lot with what we talked about earlier. And I think what you're talking about here, I don't know if you're saying maybe murmur or maybe palpitation, if you're saying it's an audible one, or if you murmur, you're hearing like a valve change, you're listening to it through the stethoscope. That would be my follow-up question there. But if you were saying like, is it more like a palpitation where you could hear it or feel it? Certainly can. That's like we talked about before with changes in cardiac output, changes in vascular constriction or size, leading to turbulence within the system, and that's oftentimes what we feel as a palpitation. As far as a murmur goes, murmurs are typically more related to valvular systems, where you have the kind of the four main valves. You have valves in your heart, and sometimes those valves can have anomalies in them that can cause different heart sounds when they close. They can be stiff when they causes a turbulence, or they can be damaged in a way where they cause regurgitation, and those things are really helpful. Cardiac echoes are super useful for that, and so if that's what you're noticing, that might be worth checking out. Sanders asking a question, did I mean that the treatment is the same for every cause? I don't know what that is causal to. I would say that I am mostly here spending my time to say, from my perspective, the treatment should not be the same for everything. Different causes would lead you to look at different solutions. So that's what I would say. Thank you, Christy Lee. I'm getting to this question way later. So it's choreography by KM. Now I'm with it. I feel silly, but thank you for clearing that up with me. Brandon says, hey, Doc, thank you for all your informative content. Thank you for being here to share it with me. Do you know of any conditions that could cause a ratchet-like tremor on eccentric movements, not rigid? I can send a link if that's allowed. That's one I could talk to you about, like offline, if you want to send a link. But on an eccentric movement, what you're talking about with rigidity is kind of like that. That's like the classic, what we would call cogwheel rigidity. So especially like if you're bringing your arm down and you're noticing that kind of movement there. A lot of people will notice like coming down from a sit up, like a truncal ataxia, like, and you feel that rigidity. You're just looking at like the smoothness of a muscle contraction, right? So rather than it being really smooth, it's happening in segments, which means that the output of that motor system is compromised in some way. Why it's compromised, I don't know. You kind of want to go through the loop. I'm going to show you guys a loop that the way I think about a lot of things. It might be useful especially for the practitioners amongst you. I think those of you that are not practitioners will also find it useful. But I made this when I was teaching about dysautonomia a long time ago, and it kind of just like encapsulates some of the way I think about, like problem solving. So let me see here. So I usually write it up like this. So we've got kind of the central motor system that's like processing in the brain. Is that coming up? No. And then you've got the peripheral motor system, and then you got the peripheral sensory, and then you've got central sensory. So, right, so it's kind of like this matrix. But if you think about it, if I feel something, right, I feel it in the peripheral system, like these are my nerves, my sensory nerves, and my sensory nerves transmit information to my brain, where they get processed in the central sensory system. So like this is in the brain. And then that central sensory system makes a picture and then transmits it to the central motor system so that we can combine that with a plan, and then we can execute it through our peripheral motor system. That's our, like the nerves that control movement outputs. And that leads us to a sensation, and we get a feedback loop, and we start it all again. And it just becomes kind of like this loop in the way that we can think about communication, right? So if we think about that communication going in that direction, if I know that peripheral motor system is decreased in its functionality, then I want to think about what would be happening either in that system. Is it breaking down, or is it something that's before that? Is it in the central motor system? So is the program that's being sent out, is that where the problem's at, right? And then so I'd want to do tests to see if we could triangulate to that central motor part. And if we're able to say like, well, we can generate some aspects of that motor program that work, then we would back out to the central sensory system and saying like, well, maybe we're just not getting good information in that would allow us to have a good motor output out, right? And then we'd look at processing here. So we'd say, well, if one processor is processing multiple pieces of data, let's look at each of those inputs and see if they all suck. If they all suck, then there's a chance that that central processor is failing. If they don't all stink, sorry for using the suck word, if they don't all stink, then maybe it's just certain components of that pathway, or the peripheral nerves themselves aren't transmitting up to the brain effectively. So then we work backwards through the system, and this is kind of the simplified version of the way my brain works in trying to understand these problems here. So in this particular one where we're looking at an eccentric movement, that's kind of what I'm suggesting is we have a motor program that's failing. If you're able to generate power, it might not be a peripheral nerve. So the next step would be to look at the central outputs and look for correlated things. So does it just happen like in the arm? Does it also happen in the trunk? Does it also happen in the legs? Is it also happening in the head? If it's happening in all those places, it's probably not from one spot, right? It's got to be like, where do all those things converge onto each other? And then you start working backwards from there. So hopefully that's useful for you. Irene McBean said, I found out something interesting at the diaphragm. The only nerve that motor innervates the diaphragm is the phrenic nerve, which passes through an acupressure point lateral to the navel here we go. Deep relaxation. The phrenic nerve travels straight up the trunk and blossoms in the right occiput area, the same place my head injury. Just one. Yeah, so the phrenic nerve controls breathing. It's a somatic nerve, meaning it controls like somatic motor systems, so like motor systems of the body. But the phrenic nerve's only job, it has nerve roots that come out of the third, fourth, and fifth cervical vertebrae on each side, travels down, comes down through, and it innervates the diaphragm all the way across. And you can see these are really important. So a lot of times I did a presentation talking about the scapulohumeral reflex and how that can be associated with injuries in the neck and outputs in the kind of the middle part of the neck. And we correlate that a lot with looking at the breathing apparatus. So a lot of times when I'm looking at people laying down, we'll look to see if when they breathe, if the ribs are moving symmetrically. And a lot of times you'll find on the side where people have change in the output, so they might have increased reflexes on that side, they might be tense or rigid, they might find that there's cramping and weakness. Then we also may notice that there are changes in the breathing on one side versus the other where the ribs don't expand the same way. And then that can lead to changes in back pain, and away you go, right? So that can be really useful. We look at it laying down and you can see it. I actually had one case of a gentleman who came in after having a disc injury and was having a hard time breathing. And I just had him lay down to take a look at him. And I was standing at the head of the table looking like down his head toward his chest. And I could see when he was breathing that like only one side of his chest was moving, not the other side. And wasn't having any consolidation in the lungs, nothing like that. So I knew that he'd had a neck injury recently, and he's an older gentleman. And he walked in, kind of like hunched over, and he was hurting and he couldn't breathe. So I just kind of took his head and I stretched it tall like that while he was laying down. And as soon as I did that, he went, and like that whole chest wall expanded as he kind of took the pressure off that nerve. So it was like, all right, so we just got to figure out like how to make that permanent. And, but that was just like a really like succinct moment in my brain where we really got to look at the relationship between those third, fourth, and fifth branches and the effect that it has into that phrenic system. Cool. Love it. Eileen said hi to Christy Lee. Christy Lee, very popular today. I love that. One of my favorite people. Dancing Pea, Peace Love Mung Bean. When I do vestibular migraines, stretches for my neck, and pain and tightness, my neck crunches. Yeah, a lot of you are going to probably have some war stories of neck crunching as a function of different injuries in that system. Saying hi to Eileen. Fatima says, good evening, everyone. You rock. Okay, so I'm at the 8:30 question, so I'm falling behind quickly. Okay. When I have a near syncope episode, or even just hard work enough to feel my pulse around the occipital bones, I sit down and my heart rate gets down in the 90s, is when I feel even worse. Thoughts? Let me read that again. When I have a near syncope episode, so pre-syncopal, or just working hard enough to feel pulse, like getting the heart rate going around the occipital bones, I'm assuming it's back here, and sit down, heart rate gets down into the 90s. So we're assuming that it was up higher than the 90s to start. And that's when you feel worse. But I don't know particularly what worse is. So I want to answer this question, but I'm not sure how to just yet without some more information here. I'm sorry about that. Practitioner says, you mentioned body mechanics in a previous live. I'm thinking my severe pelvic tilt or lordosis is also affecting POTS. I'm learning so much here. Thanks. Yeah, posture matters for a lot of the ways, because if I'm a chiropractor, so I feel like talking about posture becomes like the chiropractic trope, but particularly when we're thinking about circulation, positioning really matters, because the arterial walls and the venous walls are compressible, like they're not titanium. So things that we do have the ability to create compression within them. Now, if our body responds really well and is really on it, a lot of times we can just get through those things because our body like just shifts gears and deals with it. But if you're having a hard time being able to do that, like if that's the thing that's not working, then you're going to notice all the postural things that we normally take for granted that we can deal with become problematic. And I think that's a really good insight on your end. Okay. Is there a bra or I see your question here, Sandra. Have you had a case injured after robotic surgery, and in what way? I don't know how to answer that one. Is there a bra or brace you could recommend to improve posture? I feel because I'm in chronic pain, if my head and neck, I tend to hunch over. Yeah, a lot of people do. That's an antalgic position. We're working through that with somebody right now, actually. If you're on, you know who you are. She's doing great, by the way. Super hard worker, love it. But some of the things that we started to think about in that realm, from a bracing perspective, would normally be like clavicular braces. I don't recommend them for everyone, and you probably have to qualify yourself, but you can get them on Amazon. And they just basically, it's like wearing backpack straps that pull your shoulders back. If you want to get a little fancier with it, the Form bra, F-O-R-M-E, they make a bra that's pretty tight. Ugh. Hard to get into. You really got to get in there. But once you're in there, it really opens your shoulders up. In our experience of recommending them and troubleshooting with them, people wear them for shorter periods of time, but they are harder to get in and out of, as I've heard. Not experienced it, but that's word from feedback. So when you put it on, you kind of want to be able to wear it around maybe the house, and then be able to get out of it, take a breather, but start working toward that posture. And those can both be tools to help you kind of get upright, and they both work really well, if that's the problem. Okay. You-Rock says, it's the first live. Thanks for all you're doing. How long does the first evaluation in the office last? Depends on what's going on. What do we need to talk about? What do we need to do? Yeah, it's kind of like based on what people need, but we have, when we do it, we have kind of a long exam with a history and examination. And then we do for the people that need it, we do advanced testing as well, where we'll do an autonomic battery, do vestibular oculography, we do psychodometry, we do, if necessary, we'll have people go and have an ocular computed tomography done with a fundus photo. So we just have a lot of things in our battery that we can do. What's fun about the way we do it is that we don't have set rules with how we approach people. We look at everybody like, hey, we're all humans. Let's figure out how to solve this problem. Whatever we need to do, let's try to figure that out. But it usually takes people the better part of a day by the time we go through everything. But one of the pieces of feedback we got recently is that people are pleased that we can do our testing and then we can sit down and review it right there. So it all happens in a day, which is pretty sweet. We're really proud of that, and we really work hard to be able to do that. I know sometimes I'll see people that get an MRI and they're like, yeah, I got a schedule to read it in a month. And it's like, man, that caused a lot of sleepless nights. I know what that feels like. I've been in that boat. So waiting for the test a lot of times is like, it feels like the worst part. So I really love that we can do the test, we can sit down, we can talk about it, we can get to it, and we know pretty quickly what we want to do. And so I like that. I like knowing that we're not leaving people hanging for a while. You Rock says, first live. Cool. I'm loving that you're here. Thanks for being here. Tracy Poland says, have you had any other patients that have had heart rate drops along with POTS? The cardiologist said it was a vagal nerve response and something I never had before I had POTS. That's really interesting to see, especially if they're transient. You'd want to know if the POTS is kind of like stable background, if that's what it is, or if we're having different changes. Like, it's interesting to think about how head movements and posture affect those things. Because you can have elements where in the same one pathology of a whiplash, for example, just use that as an example, you can have in one person, in one pathology of a movement, you can have spinal cord, like spinal myelopathy, right? So changes in the cervical spinal cord, which causes its own set of problems, tachycardia being one of them. You can have changes in venous return, so pressure building up in the head. You can have changes in arterial return, hard to get blood into the head. You can have problems with peripheral nerves where we're getting pain from the neck or headaches. You can have changes in vagal output where we're starting changes in the heart, the lungs, the gut, right? So like one injury can affect all of that stuff. This dang neck is so stinking important because everything that gets transmitted from your head that's in order being placed on your body has to go through there. Anything that's information that your body is like, hey, head, I think you should know about this, has to go through there. So, and then like everything about your consciousness and like being able to have executive function is about being able to get blood and oxygen into your brain. So it's hard to overstate how important that is, especially if you think about people that have hit their head, injured themselves in an accident, any sort of trauma that affects like your head and neck. So yeah, so that would be my feedback there. A lot of questions about how do you get to that, but it's certainly not out of the realm of possibilities. Dancing P says, I get the disequilibrium sensation, but I feel it worse when I'm out doing my walk. I just keep going until I do 15 to 30 minutes with a little melty face. I love the heart, the strength to want to keep going. That's my favorite people. But yeah, the more you're up and out, so you think about like oxygen demand as you start to breathe hard. If the environment is difficult, it's just more to process. And also if we have this kind of back and forth movement of the body coupled to the vestibular system, sometimes people will notice that they get oscillopsia and like they're not able to stabilize their vision against their moving body. So there's probably a lot of people out there that have that same sensation that are probably like, I know exactly what you're talking about there. Okay. High histamine and cortisol make POTS worse. How do you manage and treat these without making the POTS so much worse? Well, these assume that they're not relative to the same thing. So cortisol, you're saying, okay. So taking these apart is pretty important. So we're starting off from the assumption that someone has high histamine levels and high cortisol levels. That should be measured out and made sure that those two things are true. High cortisol levels relative to what, and then high histamine levels are going to be related to immunological outputs. Super common in people that have toxic exposures, trying to get rid of stuff, but also common in people where we see spreading of immune activity. And by spreading, meaning we get generalized rather than specific activity. So these are super common. Most of you have heard me talk about this before in the live streams where there's a test that was commonly done. We used to do a wheel test years and years and years ago where it's like a scratch test that the allergist would do, but we do it in people that don't necessarily have an allergy. We just like we scratch it, we look at the size of the response relative just to that, and we couple that to what we see with the integrity of sympathetic outputs, meaning are the sympathetic outputs managed in the way they're supposed to, or are they becoming generalized and hyperactive? And for a lot of people that experience histamine responses, they may be experiencing that generalized sympathetic activity that's converting into an immunological consequence. And that's important. So anytime I think of kind of all of these like chemistry related things, it always pulls me back to like, well, why is that system overactive or underactive? And when you ask that question, it's more empowering to help you understand why, rather than saying, I just want to suppress the activity. So my experience has been by managing underlying features. So if you talk to, like, if you look at the way we do it in the clinic, and people that are on the broadcast would know that, like when we see someone with POTS and they say, well, my heart rate is high, I don't say, well, let's figure out how to get your heart rate down. We say like, well, let's figure out why it's high, and then let's solve that problem. And we just solve problems until your body's not having to freak out anymore, not having to overcompensate with these things. So maybe just like changing the perspective on that might be useful to not feel so encumbered by some of that chemistry. So hopefully that helps. Ripvik, good to see you. Thanks for sharing your knowledge, Doc. Much appreciated. Thanks for being here again. I appreciate you. Is there something that post-infection POTS can learn about recovery from other POTS patients like astronauts and athletes like Katie Ledecky? Interesting idea. So I think that that's true. Like a lot of what we're trying to solve for is how do we get people back into a life of movement again, a life of activity. And I think I'm on board with the idea that we want to use physical activity as a measure, but I think we also have to be aware of a lot of the people that I see will note that one of the things that calls their attention to the fact that something is wrong is because they can't exercise anymore. So a lot of people come from being athletes and realize like, I'm falling apart trying to exercise. And that becomes like the catalyst for them knowing something is wrong. So I like the idea of holding your output levels and your energy levels to stable the best you can, but then also trying to understand why it's failing in the first place. I love it if people, like if it's just deconditioning, then you just work hard and you get better. But a lot of people will notice that like over the course of months that just like working hard isn't cutting it. If you're cranking away and your heart rate's super high and you're exhausted just walking around, it's hard to exercise your way out of that. You're already exercising just like existing. So I love it. I love the idea of using exercise. I wish we could solve all the problems with that. But then the way I think about it is like, well, why isn't my body able to use this exercise the way it normally would? And what are the barrier constraints to that? What are the reflexogenic problems that just aren't being executed? And then how do we work from there? Notice blood lactate levels being elevated in POTS patient, even if they've not been exerting. I haven't noticed that, but it's a good question. Doesn't mean that somebody else hasn't noticed it. It's just not for me. Kindle Ahrens, hello. She says, hello. I have POTS and I recently developed PVCs. My cardiologist told me to increase my beta blocker and drink more electrolytes. Nothing is helping. Any suggestions? Yeah, PVCs are not fun. No one likes the fish flop is not great. But suggestions, increase the beta blocker. Again, try to slow your heart rate down, seeing if that creates some rhythm. Some people, it helps with PVC. Some people it doesn't, and it makes it more uncomfortable. Electrolytes, because you're trying to balance out the sodium potassium to try to see if there's any electrical arrhythmias. If their burden is high, I don't know if you've done, again, I can't give you medical advice. I can't do that through the computer. But things that people would consider are just running a simple Holter, making sure the electrical systems are doing okay. Obviously, it's a cardiologist. We would hope that that's being done. If the electrolytes aren't changing it, then you want to probably confirm that all of the cardiac function tests are within normal ranges, and then you're gonna probably end up looking toward the neurogenic stimulus in the heart. So sometimes that, like, if you're worried about it being within the heart tissue, they'll send you to an electrophysiologist if the PVC burden's high. But if it's possible, just from the nature of running tachycardia for a while, you can develop PVCs as well. So those are things to consider. The electrophysiologist can be helpful if there's something that's electrically wrong in the heart. Otherwise, you're headed north of that and you're looking for how the brain's communicating with the heart and seeing why that's becoming arrhythmic. There are a lot of reasons for that that can be pretty resolvable, but it's worth checking out and making sure none of the like intrinsic cardiac problems are there to start with, just to kind of rule that out. Jeremy Schwartz, hello. Okay, Jeremy, I'm going to answer your question. I love all these questions. I'm going to answer questions till 10 and then I got to jet. So if we don't get to yours, I super apologize. I love that there's so many to answer. I'm trying to move quickly, but I'm just going to work as best I can here. I'm looking at where my little dot is in the scroller, and I'm wondering if I'm gonna get there or not. But I'm gonna keep working through it. But I'm gonna probably stop at 10 o'clock. Okay. Thank you. In a recent post about blood pooling, you talked about recalibrating your nervous system to start sending blood back to the right places. Can you talk about that? What would that process even look like? Absolutely. So let's demonstrate. I think this is a good question. I find myself trying to describe it a lot, and I don't always feel successful. So, because there's kind of a lot of backstory that isn't walking around in a lot of people's mind on this one, myself included for a long time. But so there's this thing to consider. So if I'm pooling blood, what would have to be true? So if my blood is pooling, we would have to say that perhaps my venous system is just not working. Like all of the tension in the veins just relaxes and all the blood can't get back up to the heart. So that could be a thing. How would you notice that? We'd have like blown out veins, varicosities, all the pooling, everything would just drop into the legs. And they're usually quite painful, and that's like its own thing, right? But like a more subtle gradient of that would be that they're just like hypo-functioning, and that can happen as well. But also, that's going to be driven also in a large way by the arterial outputs. So if you have a picture of your body in your mind, this is going to be bad, but I'm going to give it a run here. So if I just have a picture of a body, we want to consider, okay, so it's like a body wearing Carhartts, okay? And let's give you a smile. And then in your brain, there's a map of every part of your body in your brain, and it's in the area, it's your primary sensory cortex. We call it the homunculus, okay? So that primary sensory cortex is just kind of like if you drop it right there on your head, and then it hooks down in the middle, in between the sulcus, like if you go straight down. So it's kind of like, looks like an M, like this going around. So the one on the left side of your head controls the right, or feels the right side of your body, and then vice versa. The one on the right side of your head feels the left side of your body. So that map is there. So any point that I touch, right, on your skin, anything that there's a sensation in your muscles, I move, anything that's a sensation in your joints, all of that stuff is like a little dot. And those dots are all communicating with your brain, okay? So if I'm not, we have these problems that people experience where they lose the sensation between their body and their brain. So, and a lot of times we don't notice it very well. It's hard to pinpoint that. But when we do different tests, we can determine if people feel their body very correctly. And when we do that, we can kind of create a map of understanding how well your brain is able to process information from your body. And part of that is if I don't feel, like, let's say, for example, I don't have good feeling in like my leg below the knee over here, right? And then therefore I also have movement troubles that occur over here as well because I don't control it very well. So let's say I'm weak there, or I'm uncoordinated there. Like I go to tap my foot, I'm tapping it on the table or on the floor. Probably don't tap your foot on the table. But if you're tapping your foot on the floor and it's just like arrhythmic, like it's hard to catch a beat, and the sensation is bad, then what we would look at underneath that is the same map of your brain that would control the output of that leg is also going to control the blood vessels that serve it. So if I've got a muscle that doesn't work accurately, the probability that the vessel that controls it doesn't work accurately is high, because they're correlated in your brain. They come from the same area in the brain. So if that's true, what we can see then is we get a mismatch in how we are going to skew our blood flow into certain areas. And that could be, it doesn't have to be like your leg. It can just be like little patches of areas where it isn't like it's dead. It just may be, there may be a couple variables to consider. So number one is latency. So the response time to get blood there may be slow. Number two would be accuracy. And that means like maybe I need blood in that leg, but I get it like to my thigh, right? Looks like it isn't accurate to the specific area I'm trying to get it to. And then number three, we think about it in terms of amplitude, which is kind of like the volume. Is it enough? So when we look at movement disorders, those are three of the criteria we're always looking at. In the same way we think about a muscle in the body not working effectively, we think about the muscles of the arterial system not working effectively within the same map. So when we have pooling, what we're trying to understand, whether it's in your gut or in your legs or in your arms or wherever, we're trying to understand, is it because peripherally we're seeing a change in the blood supply, the accuracy or the latency or the amplitude of the blood supply, and then that causes a slower return back to the heart? Or are we seeing that like neck down, everything runs great, but we're just blocking arterial systems going into the head, right? That's going to change outputs as well. Or are we seeing that the baroreceptors are getting it wrong and it's assuming we have more blood in our head than we do, or less blood in our head than we do, or the autoregulation or the ability of the brain to be able to manage that pressure is decayed, so that we see when you lay down, you get a ton of pressure in, and when you stand up, you get a ton of pressure out, like the tide rolling in and out. So all of those are ways that we'd want to think about recalibrating the nervous system. And that's just a kind of a cliche way of saying we have to improve the functionality of the map, which means the sensory, and we go back to this drawing that I gave you earlier, where we've got central sensory, central motor, peripheral motor, and then peripheral sensory systems. So I want to look at how those are working. If I know the output is my arteries aren't working great, or I'm not getting blood in my head, then I back it out and I try to figure out, well, maybe my brain just is like not processing. Am I looking for movement disorders there? And then how does that relate to the information that's coming in? Do I have a peripheral neuropathy that's the main problem? So you asked about like, somebody asked about like post-infectious people. Sometimes there's just peripheral nerves and they don't work. So we have to figure that out. A lot of times it's processing in the brain where the maps aren't accurate. And if the map's not accurate, when you go to navigate off the map, then the navigation's poor, so we get a bad output here. So that is the way that I think about calibration is through that model. So hopefully that's helpful. I spent a lot of time with a lot of doctors teaching that. So I hope it's really useful for you to understand that calibration is really looking at that chart, understanding the quality of the movement, and then backing it out to see what would have to be true for those things to fail. And then you can work on figuring out, how do I smooth that out and make it a better processing system? That's what's cool about the brain. We don't give it enough credit, that the whole thing is designed to just always get better at processing the things that you're doing. So the more time you spend doing anything, the better you get at understanding how to do it more efficiently. So like people can get good at weird stuff. You know, you see Guinness Book of World Record stuff and you're like, how did you spend that much time? But people can get good at juggling like 50 chainsaws or spinning plates or, you know, playing basketball or writing code. It's just whatever you spend a lot of time on, your brain learns how to do more efficiently. It orients more resources toward learning how to do it, and it learns how to do it. Where we run into trouble is if we've got something that's created a problem, an injury, an illness. We're trying to do a thing that is high above the dose level of what we're capable of, and your brain's having a hard time being able to make that leap. So we want to break it down into segments that are easier to be able to achieve those segmental capacities and build it back up again. And that seems really simple, but it's just a way to learn. So like if you were going to learn calculus, you'd start out with addition and subtraction and then multiplication and long division and then, then algebra and geometry, and then you work your way up, right? You don't just like start trying to do calculus. It's kind of a similar concept. If I'm injured and my brain is like stuck and it's not able to get through there, then we've got to be able to break down the resources into simpler chunks so we can build it back up again. So hopefully that's a way to understand that question, Jeremy. Thanks for asking it. Okay. Verzak, are IST and POTS mutually exclusive? They are not. So IST is inappropriate sinus tachycardia. They're not necessarily mutually exclusive, but the underlying diagnosis is important. So the IST part is oftentimes due to changes in vagal outputs. So we see increased spontaneous activity at the level of the heart, which is then going to transfer into the likelihood of POTS because it's going to speed up the heart rate, drop the cardiac output, and then we're going to end up with hypoperfusion as a consequence of that. So how do you work back through that is you solve for the thing that makes the heart rate go up in the first place, let it calm down, cardiac output goes up, perfusion goes up, happier brain. So they don't have to be mutually exclusive. In my brain, I tend to separate them because I'm thinking about underlying mechanism. And so in my brain, when I see IST, I kind of slide into a different diagnostic criteria than if I'm looking at POTS without it. And for me, when I look at somebody that has POTS, POTS is rarely the diagnosis that I'm chasing. POTS is my starting point. It's saying like, okay, this is where we enter the game is at POTS, but that's not where we're trying to get to. We're trying to figure out, okay, that is the starting place. Now, what do we really have? And then figure out what's wrong. So Fairzuck is one of my favorites as well. I hope you're loving the club. Stay away from the embassies, please. Behave yourself. I love that you're here. I hope you're still awake. Well, I kind of don't. I'd like you to sleep, but hopefully you get your answer. Anna James says, thank you. Okay. Sandra asked you, going back to kind of some of the I think this is from the adrenal and the Sjögren's conversation, that the glands are not going to be responsible for the dysautonomia. No, the dysautonomia is probably the thing that causes the changes in the output of the glands. So we probably shouldn't blame the glands. We should probably think about why they're not being communicated too well. Irene had said, could mRNA damage could damage cortisol levels? I had wildly fluctuating cortisol, now lately cortisol in the basement. Yeah, outputs change largely because we get changes in the brain. We get changes in the way we're controlling those, which sucks because it seems like every day we're finding out more and more about mRNA that is probably not things that we're like happy to find out. So yeah, I'm sorry. We're just like figuring those things out in real time. Toxins are tough, so trying to be able to be thoughtful moving forward is a gift, but it means we're fighting through a lot of things right now. And the news on that's been pretty wild lately. Sarah Adams, hello. I'm going to do just a couple more. It's getting late. My eyes are getting tired looking in these lights. Do you see POTS and PNES to be connected? PNES is non-epileptiform seizures, psychogenic, but not really for most people, I don't think. So psychogenic non-epileptiform seizures basically means like it looks like a seizure, but it doesn't have the brain waveform of a seizure. And we see a ton of these that are related to hypoperfusion, like a surprising number. And they're not all that. I'm not saying like every case of PNES is hypoperfusion, but it is amazing how much overlap there is to that. And we've actually had some people comment and say hello on this stream that have experienced that as well. And the good news for that is you go from like, we don't know what the heck to do with you, to like, oh, there's like a palpable road toward trying to solve this problem, which I think is super cool. Dancing Peace says the glucose explanation was great. I get hungry and hypoglycemia symptoms. I put on a continuous monitor. I like that. I actually like that tool. And notice that my pattern was up and down, very sharp ups and downs with lows at about 40. Um, I think for the price that they are now is wild that they're available. I've got someone right now that got one on Amazon, and can just be an interesting tool to help understand how your blood sugar is related. And a lot of times it helps people get some better dietary habits, which I love. So yeah, I think it's pretty cool. Sarah Adams said, does the lack of blood to the brain so much due to POTS cause damage or bring on higher rates of certain conditions later in life? Not to scare people, but it seems like it does. Just like if you have low blood flow for a long period of time, your brain starts to try to figure out how to deal with that. And then we start to see some of the conditions where we look at like things like vascular dementias, vascular Alzheimer's. These are things that people are starting to notice more. So it's not to scare anybody. It's not to make anybody feel a sense of panic or urgency, but it's more like the sooner you can get in front of that and let that tissue heal. That's the important part, is like, if you can get blood to stuff, it heals, which is super cool. So let's do that. But it kind of gives you like a little bit of a kick in the butt to be like, let's try to get this done sooner than later. Because I want to get old and I want to be healthy when I'm old, right? So not to scare people, but there does seem to be some correlation with lower levels of blood flow over time, causing neurodegenerative functions down the road. Okay, so good question. Sorry, it's a tough answer. Robin, during my dysautonomia research, many report their dysautonomia starting as a side effect of surgery. Yes, can be. Any surgery, what could explain this? I suspect it's how general anesthesia is applied. I also think that too. That's been my experience with interviewing people and going through their histories, is general anesthesia seems to be a catalyst for people. Other times we can have secondary nerve injuries where just on an incision or while they're mucking around, they can nick a nerve or things that they don't expect to be a problem but can be. But anesthesia is kind of like the thing we want to prove out first, and try to work through. But yeah, good observation. That's the same one I've had. Irene says, I could functionally travel. I just don't have someone to drive me to Michigan. Well, Irene, maybe somebody here is looking for a road trip and they would be a great fit. That's a good point. Maybe planes or trains might be useful for you, or maybe trying to see what could be done at home and work from there. She said, great point to Rob. Hers is after brain and spinal surgery, cervical surgery. Yeah, cervical surgery and cervical injury kind of overlap each other quite a bit. So those can be tough. Yeah, and Rob is making the point that it can be from ankle, shoulder, dental surgery. That's been my experience too, where it can be just anything. Yeah, so I think that's a good insight. Dr. Ginia giving a little help to HH and Irene, said, I took a bunch of Benadryl and Dramamine when I drove up for the first time. Not the best, but it got me there. Yeah, that was roughing it, but here we are. Can a ketogenic diet help with mitochondrial function and brain health? It can. You're looking for things that allow a more simple translation of electrons and it's kind of like the quality of the hydrogen as well. So the hydrogen ion is interesting based on its ability to carry charge with a proton and a neutron. And it's like the quality of the hydrogen actually affects the ability to go through the fourth component of the cycle in the mitochondria. It's a long story, but ketogenic diet can be useful. Things that are non-inflammatory. Getting sunlight can be really useful because there's the responsiveness of mitochondria to red light chromophores is super high. Like they're red light responsive, which is also why people have made suggestions for methylene blue in the past, using red light therapy, getting out in the sun and doing heliotherapy. All of those things can be beneficial for mitochondrial health. Using the tissue. Using the underlying is really important, because it's like the old, if you don't use it, you lose it. The utility of the mitochondria comes from activation of the neuron, and activation of the neuron within the substrate of being able to have highest energy transmittance, which is going to be using things like light and quality energy sources. Processed foods cause changes in hydrogen ions that allow them to be kind of big when they try to go through, and they don't it's kind of like a little oscillating door that have to be moved through to create the ATP, and they can get to where they're too big, and then it doesn't fit as well. So even though the hydrogen's there, it's not as functionally useful. So that'll be helpful. And somebody else mentioned a comment here on methylene blue. Again, I mean, if you can use just natural sunlight, that's probably my favorite. Methylene blue started off as a clothing dye, so it's not like my favorite thing to use, but there are people that have been really supportive of it, shown a lot of success. They did some studies down at a retirement community that seemed pretty promising for people. So I don't know, I can recommend it, but for some people have definitely found it super useful. So I would not recommend it, but it's just not like within like what we do on the internet here to recommend that. Okay. I do one more from Gwen. I was told that it is well known that having POTS can lead to having diabetes. Is that true? I don't think so. I think you got hemodynamic issues. If you affect the output of the signaling to the pancreas over long enough periods of time, you can. But a lot of people also start to develop malabsorption issues, and then we see changes in the actual like blood chemistry because of like misuse, disuse sort of thing. So anything that affects autonomic outputs for a period of time has the ability to make anything go bad: kidneys, liver, gallbladder, pancreas, whatever. But interestingly, we probably want to focus on solving the problem at hand, and then managing glycemia so that you're able to like have stable glucose levels goes a long way in trying to smooth out the edges. But if it's true like blood flow problems or hemodynamic problems, you'd probably want to think about addressing those separately. Cool. All right, team. It's 9:57. We got people to take care of tomorrow, so I've got to get to bed. Looks like I made it through all the questions that were submitted by about 9:03. There's been a lot more since then. Apologized for that. Man, hopefully you guys were able to communicate with each other here a little bit. Oh man, I feel like I want to get to these, but I gotta get going. Okay, you guys are awesome. I'm just looking through some of these questions. These are good questions. I gotta figure out if I can keep a hold of these and then maybe pick them up later or try to answer them again. Yeah, Rob here said, I recommend everyone watching Chris Gasquion's 3-hour vlog on YouTube where he shared his experience with us. I interviewed him for like an hour. Dr. Kipros was on there with him as well. He went through his whole experience there. He just threw it all out. So Chris Gascoigne, I say that wrong every time, Chris, I'm sorry. Gascoigne. Just my favorite British Chris is how I know him. But he actually did a really nice video if you guys are looking to get into some deep content there. Okay, you guys are great. I will do more to try to keep doing this. We'll keep doing it every week. I'll try to keep answering these questions. I realize I missed quite a few. And I'll try to get you there. Okay. I'm just trying to get these in my head because I think when I close the stream, these kind of go away on me pretty fast. So I'm just trying to check in on them here. Okay. Well, thanks again, everybody, for being here. You guys ask great questions. I hope I can just try to answer them best I can, and we'll just keep working at it and do whatever you can to try to just make tomorrow a little bit better than today. Let's grow a little bit at a time. I'll be back next Thursday, 8 o'clock. I hope to see you guys here. Bring your questions. If you want to send them early, you can send them to the email, and we'll try to get them on. And maybe as we get going, we'll try to think of better ways to consolidate that so we can get more questions answered. Okay. All right.